Good morning. Today we will be dealing with several obstetric operations. Since there are 4 operations to be dealt with, I will be concentrating on main points of each operation. So the operations to be discussed are episiotomy, cervical cerclage, vacuum extraction, and among the forceps application, it will be low forceps mainly, which will be discussed. So all these topics are important both from theoretical as well as practical point of view, and in theory mainly they will be in form of short questions. So today's specific learning objectives are, at the end of the class, the student should be able to define episiotomy, describe indications, types, procedure and complications of episiotomy, describe indication, procedure, complications of cervical cerclage operation, describe types of assisted vaginal deliveries, their indications, contraindications, prerequisites of each surgery to be done and their complications, and describe types of vacuum cups and various types of forceps and the procedure of vacuum extraction and low forceps deliveries. So first topic to be discussed is episiotomy. But before we go into the episiotomy proper, let us recapitulate the perineum, which is a part which we will be cutting during the episiotomy. So obstetric perineum. This is a pyramidal shaped tissue where the perineal muscles and fascia meet in between the vagina anteriorly and the anal canal posteriorly. So, and it consists of, like we said, fascia. Fascia is superficial perineal fascia and urogenital diaphragm. And the muscles which are there present in obstetric perineum are transverse perineal muscles, both superficial as well as deep, bulbospongiosus, sphincter ani externus, levator ani, and longitudinal muscle coat of rectum. Obstetrical perineum or perineal body, it's also known as central tendon of perineum and perineal body, is actually a mass of dense tissue, and then there is a distal 1/3 of the posterior vaginal wall and the anus. So it's a pyramidal structure if you see in the 3-dimensional view. So what are the perineal muscles present in the perineal body? One is bulbocavernosus, surrounds the orifice of the vagina. This is the bulbocavernosus and covers the vestibular bulbs. And the superficial transverse perineal muscle is a small strip that arises from the medial side of each ischial tuberosity and joins its fellow in the central perineal tendon. And deep transverse perineal muscles are the most posterior fibers of the sphincter urethrae. So this is little bigger picture. Here we can see the bulbospongiosus and transverse perineal muscles, superficial transverse perineal muscles, below which, or above which will be the deep transverse perineal muscles. So these two muscles are important from the episiotomy point of view. So coming to episiotomy, what is episiotomy? It is a surgically planned incision on the perineum and posterior vaginal wall during the second stage of labor. So it is purposely this incision is done. So, and the word episiotomy is derived from the Greek episton, which is a pubic region, and tomy, that is to cut. So episiotomy, as far as the literary meaning is concerned, is incision of the pudendum or the external genital organ. The most rather the relevant or more appropriate word will be perineotomy. However, this perineotomy is usually not used, or it's used along with the episiotomy. So what are the objectives or performance of this surgery? The main purpose is to enlarge the vaginal introitus so as to facilitate easy delivery of the fetus, both in spontaneous delivery or in manipulative delivery, and to reduce the second stage of labor in cases of fetal distress and where prolonged bearing down may be harmful, like in cases of severe hypertensive disorders or cardiac disease, and to minimize the overstretching and rupture of the perineal muscles and fascia so as to reduce the stress and strain on the fetal head. So episiotomy need not be given in every case of delivery. So what are the indications of episiotomy? The most important indication is rigid perineum, then the anticipating perineal tear. So like if there is a big baby, or face to pubes delivery, that is in occipito-posterior position, breech delivery, or shoulder dystocia, so where we may have to need manipulation. So there you want a larger space. So there, if you don't, episiotomy is not given, perineal tear can occur. Then operative deliveries like forceps delivery and ventouse delivery, and previous perineal surgery like pelvic floor repair, perineal reconstructive surgery. So common indications are threatened perineal injury in primary gravity, rigid perineum, forceps, breech, occipito-posterior or face delivery. So it's important to time the episiotomy properly. It should not be too early or not too late. So and if it is done too early, there will be bleeding for quite some time, and if it is done quite late, then there are chances that perineal tear can occur. So it should be timed when the perineum is bulging and thinned out during contraction. So just before crowning, that is when the baby remains visible, the head remains visible through the vulva, even when the contractions are not there. Just before that stage, the episiotomy should be given.